Hi, everyone.
Hi, Dr. Andrea. Such a pleasure to see you. We're so happy to be hosting you here. Welcome to India's first mega event on metabolic health and low carb nutrition. And welcome to India.
Thank you. Thank you so much. This is just incredible. I'm so honored to be here and to be on this list of wonderful speakers and wisdom, truly, that is going to be shared with the world. So thank you so much. And thank you and hello to all of my Indian family. And I'm just so happy to be here. So what an honor. Thank you.
So, Dr. Salcedo, let me just introduce you. We from the DLF family have connected with you earlier and we've spoken quite in depth on women's health, but I'd like to take a moment and introduce you to our larger audience as well. So Dr. Andrea Salcedo is a gynecologist and obstetrician practicing in California, USA. With 20 years of experience in her field, she also specializes in metabolic health and uses low-carb, high-fat diet as an adjunct in the treatment of abnormal uterine bleeding, irregular periods, polycystic ovarian syndrome, and many other gynecological problems. She's currently an assistant professor of obstetrics and gynecology at Loma Linda University of Health. She was also the medical director of general gynecology services. She's a medical expert at Osteopathic Medical Board of California. She's a medical consultant at the Noakes Foundation and a Nutrition Network certified practitioner. She's certified by the American Board of Obstetricians and Gynecologists and the American Osteopathic Board of Obstetrician and Gynecologists. So Dr. Andrea has also published quite a few research papers, predominantly on women's health and abnormal uterine bleeding. Two of her papers are carbohydrate restriction therapy and how it helps in prevention and treatment of abnormal uterine bleeding, insulin resistance and other risk factors of cardiovascular disease among women with abnormal uterine bleeding. These are the two papers that she's published. She's also a practitioner of low carbohydrate lifestyle and strongly recommends it to her patients, along with using it as part of the therapy. She's highly skilled in her field and is known for her exceptional medical expertise and compassionate patient care. She goes by her Twitter handle and other social media handles as the Conscious Gynecologist. So Dr. Salcedo, that's a lovely handle, the Conscious Gynecologist. I think it makes so much sense when you're not just looked at as a doctor, but you're so conscious about so many other parameters that are missed by regular medical experts. So firstly, I'd like to ask you a bit more about yourself in terms of how did you get in touch with low carb? How did you adopt it and start believing in the LCHF paradigm?
Thank you so much. That was a big introduction. And I think, wow, how do I have almost all this time? But I really do appreciate it. Thank you, Shashi and Anup, for the opportunity, as well as Anjali for your time. Yes, I am a full scope OBGYN. I do surgery from cesarean to hysterectomy. I deliver babies. I take care of women all through their phases of life. Just yesterday, I saw a 10-year-old and a 75-year-old. And so there's a huge range of problems in women that I take care of. But really what I think when we're looking for our purpose and trying to figure out what we're going to do in life, we think about what keeps us up at night, right? What are the problems that we're trying to improve in the world and in our own, sphere of influence. And to me, I was starting to feel frustrated with routine gynecologic care because when I was in training, I was able to have, I was married and had my first son, and it was very easy. But then when I graduated and I became practicing in a very busy practice, I was making a lot of money and I was just really flexing my clinical skills. And I just couldn't get pregnant and I couldn't figure out why. And I was having normal periods, but they were really heavy and very painful. And but I thought because I was having regular periods, I should be able to have a baby very easily. And I ended up with a big endometrioma, which is like a big blood-filled cyst on my ovary. And I got it removed, but I had to lose my ovary as well. And my gynecologist, just like most gynecologists who have wonderful intentions, recommended that I be started on birth control pills. And I just didn't accept that. I just felt like there has to be more. All this training, years and years, there has to be more, because birth control pills didn't make sense for me. I was trying to have a baby. And so I decided to really take a close look at my life, and probably a lot what Dr. Lenski's was describing right now too, is lifestyle management, looking at stress. And I quit my job and I decided to focus on myself and reduce a lot of the stress. And not 4 weeks after I quit my job, I got pregnant, and I had a miscarriage, but 2 weeks later I got pregnant again, and I was able to conceive and had a wonderful delivery, and it was no problem. And wow, that just was such a very interesting lesson for me to learn that, wow, I was able to kind of figure out my life. And I started looking at nutrition and how that really did play a role in my balance. And I started looking at gluten-free diets and looking how that played a role in my endometriosis, and it helped a lot. But in the States, a lot of the gluten-free alternatives end up being a lot of corn and grains. And I still was having struggles with heavy periods, even though I didn't feel too symptomatic as I was before. And I ended up starting my job at Loma Linda, which is a wonderful institution of learning and lifestyle. And I wanted to have another baby. And when I got pregnant with my third, I ended up getting gestational diabetes. And I was 120 pounds and 24 weeks pregnant. I couldn't figure out why I had gestational diabetes, and neither could my colleagues. And so, I mean, my 1 hour glucose test, and I don't know if there's what the conversion is in other areas, but it was 197. It was really high. And so I couldn't figure out, I was eating grains and chicken and low fat. And I just was like very surprised. Well, I was personally determined not to go on insulin. And so I started reducing a lot of the carbohydrates, even though that isn't standard of care. And so I really, really, really was strict and reduced in a lot of the simple carbohydrates, and even the quinoa and the grains and the rice and the brown rice. And I became probably, too low, but I don't know if that's even a thing, but it felt absurd in where I was at that time. But my son was 6.5 pounds, about, little less than 3 kilos, full term. The delivery was super easy. And then during my postpartum recovery, I just started diving into how there was such little information that women needed to help really reduce those risks of gestational diabetes, chronic medical problems in gynecology. And so that's when I found the Nutrition Network. The Nutrition Network started teaching me that the organs receive inflammation, just like, the kidneys and the liver and the heart, and they receive organ damage from hyperglycemia. And that's when the light bulb moment happened. The light bulb moment happened where I felt like, well, why isn't the uterus considered an end organ that receives inflammatory change just like any other organ in our body? Why not the ovary, right? So, man, that just opened up so much room for investigative discovery and creative thought that I really dove in, and I just immersed myself in this culture. And that was about 6 years ago. And so here I am, but just like you, Anjali, just feeling frustrated, feeling confused, and wanting more. And that's where I am today. So. Oh, sorry. I think you're muted, my friend.
Sorry. Yeah. I said that is such a journey. I mean, it's so risky, especially during pregnancy, for someone to even change from or deviate from the normal care pattern, right? Or take any risk with their dietary patterns. I think that was something very brave on your side. So now you also mentioned that ever since you've learned about nutrition and you've learned about low carbohydrate and the uterus problem. So now you did mention that you use low carbohydrate therapy as a supplement treatment for gynecological problems. Can you help us understand a bit more about that?
That's right. Very good question. So the fundamental concepts are basically high insulin levels and inflammation. Okay. And so most problems within gynecology seem to stem from those two problems. So there's either an elevation in inflammation that can damage our blood vessels and lead to, fibroids or impaired receiving of the ovaries to receive oxygen and nutrients to have healthy ovulation. But also elevations in insulin can actually block our what we call the hypothalamic pituitary ovary axis, which is the signaling from the hypothalamus to your pituitary gland to your ovaries to cause ovulation. And a variety of factors can influence changes in the inflammation as well as the insulin level. And it's not just diet. And sometimes it is, simple carbohydrates and processed food. But other times it's not sleeping well. So other times it's stress, anxiety, intimate partner violence, low vitamins, sleep apnea. Sometimes it's even things like not a very good job, feeling a little bit undervalued. All of these things really do activate our trauma response, our inflammation response that damage our blood vessels, and our blood vessels will supply all of our organs, and they also elevate our insulin levels. And biologically, women, and I'm a professional woman, and I really support women doing lots of different things, but biologically and evolutionarily, we were made to have children. And so when our body senses that we're under a stress, then it's going to protect us from reproducing during a time in our life that might be unfit. And so that's where elevations in insulin come, and it's actually a protective factor. Insulin is a protective stress hormone for women particularly, so that we do not conceive at a time that is not appropriate. Because if you think about the nutritional investment of conception, pregnancy, and delivery, that's easily a 3-year commitment, right? And so for women, it really does impact our physical and mental health. For men, for a long time, we do really have to be ready to conceive. And so if there's anything that will influence or impact that negatively, insulin level will go up, inflammation factors will go up to really reduce our chances for ovulation and getting pregnant. But chronically, and that's okay once in a while, right? We all know that sometimes we're in stressful times in our life. Maybe someone passes away, or we're in our final examinations and we skip a period, and everyone kind of knows why that is. Oh, I was very stressed out, I missed my period. We understand that. However, chronically, over long periods of time, that really does impact a woman and can lead to polycystic ovary syndrome, other problems with heavy bleeding, but also fibroids. And then eventually, it can turn into uterine cancer when many years down the road. And so it's important to understand the impact of our lifestyle and on our womanhood. So yeah, absolutely. There's so many things.
True. So you did mention polycystic ovarian syndrome, PCOS. I think let me go to that question. This is a very, very rapidly rising issue today. Going back 20 years ago, maybe people would never have heard of this term, but right now, in India, at least 1 in every 5 women, in fact, more in girls, adolescents, and teenagers, you see a lot of them having some kind of a PCOS syndrome or some kind of a symptom which gets pointed out as PCOS. And it is increasing as women age further as well, therefore resulting in complications of conception and so on and so forth. I think even in the US, it's on the rise. It's maybe the numbers may be slightly lower, but I think it's still there on the rise with Mexican. I think it has a connection with the race as well, because Mexican American and other different races have different numbers. So, can you just give us some idea as to why there is such a rapid rise? And do you see any connect with the food, lifestyle, and this disorder?
That's a wonderful question. And a lot of times people think, well, why is PCOS even a thing? Like, what is that about our biology that has brought us to this point? And I am very interested in evolutionary biology. I've actually looked into a lot of evolutionary biology papers about the purpose of PCOS and why the gene has stayed with us for many years. And it is not just one gene. There's, different polymorphisms of our DNA that kind of predispose women to having this PCOS disposition and not. And PCOS is polycystic ovarian syndrome. It is a syndrome. So sometimes that means that it kind of comes and goes depending on your metabolism and where you are in life. And so there are many different organizational bodies that actually argue over what the criteria is, but by and large, it is usually some function of irregular periods, hair, or extra testosterone features where you don't want them. So thickening skin tags, darkening of our neck area, chin hair, those kinds of things, or losing some hair on the top of our head. And very tiny cysts on your ovaries that can be seen on ultrasound that don't require surgery. And so usually we say that if you have two of the three features, you do meet the criteria for polycystic ovarian syndrome. And honestly, PCOS is really pre-diabetes. It is some of the first phases of diabetes as it relates to womanhood. And if we think about why that is, the evolutionary biology suggests that women who are more predisposed to PCOS have a little bit of a higher glucose level, okay? And if you have the higher glucose level, the function of that is so that your body does feel nourished. It feels that there are enough reproductive and nutritional stores to conceive during times where there's extended periods of fasting. And so when we have women from our ancestral cultures, thousands of years ago, there were times where there was not a lot of food. And so because of that, we were fasting for long periods of time. And so women with PCOS features or PCOS predispositions had little bit of higher level glucose levels to allow us to continue to ovulate. Okay. And so that's why that PCOS has lasted so long, because that elevation in glucose has allowed our body to reproduce even under extended periods of fasting. Now, that being said, PCOS actually turned into a problem of modern civilization because food is so plentiful now. Okay, we can go down the store, get a stack for me and my culture, a stack of tortillas. We can get lots of bread very easily. But if you think about how long it used to take our ancestors to make rice, to cure the corn for corn-based foods, make bread, it was not something easy. It took a long time and a lot of care and a lot of just caring for the nutrients itself, that we didn't overeat on a lot of these things. And so but modern civilization, because of how plentiful the food is, it has really raised our glucose level, and then as a result, raised our insulin level. And then it starts the cascade of elevated testosterone and blocking our ovulation. And so honestly, PCOS is a disease of modern civilization, because all of these genetic polymorphisms that have been present in so many women were present for millennia, but really are more prominent now in a pathologic way in modern times. But it was actually something that helped us, for thousands and thousands of years. And so you're right. People of color tend to express this a little bit more. The actual prevalence in the world is about 10 to 12%. However, in particularly in diaspora cultures, so in cultures like the Mexican American folks that come from Mexico or Latin America to the United States, Indian families that migrate in other areas. And I think that one of the studies that I read in the United Kingdom showed that 50 to 60% of, South Asian Indian women have PCOS. That's a huge number. And it really has to do with so many multifactorial factors of not only diet, but the stress of the immigrant experience, right? The stress of the immigrant experience is also very prominent and causes elevations in insulin levels too. And so it's not just diet, but all of the other factors that are involved. But yes, it is definitely a disease of modern civilization.
So what I understand from what you're saying is the so-called PCOS, some of the symptoms, you're saying that is inherent, that was there, designed for protection, designed for the betterment of a body, but it's becoming, or it's turning into a wrong way simply because of the evolution of our society today, simply because of how we've shifted our food habits and moved to wrong or bad lifestyles. Am I right?
Yes, it's just, too much exposure to carbohydrates, plentiful foods, and the modern lifestyle. Absolutely.
And let's not forget the stress, right?
That's right.
So when you were saying primarily, because PCOS, you say, is a pre-diabetic case, and I do see patients, being prescribed metformin, which is a diabetic medicine, as one of the first steps in resolving this. I see a lot of women who are, which may be on the obese side, and you can see that they have overweight and they have some pre-diabetic symptoms, and you can see the insulin resistance there. But I've also seen, on the other hand, young women, girls who are not so obese. In fact, a few of them are underweight, and they still show a PCOS issue. They still show a lot of these symptoms. And these are all the young ones. I mean, college-going students, late teens and early 20s, those kind of a population. So could you just bridge the gap between these two?
That's an incredible question. And it's something that's always on my mind too. And I start to notice it clinically. You're right. And when I describe to patients about how their body deposits fat and inflammation, it really is a difference between how their genetic makeup has directed their ability to process sugar. Okay. And so some people, and these people, there are some people who are very thin, stick straight thin, and they can eat pretty much anything and they don't get chubby. And you can kind of see a little bit on their tummy, that maybe they kind of carry it in their tummy, and it's very frustrating. And then there's the poor person who can barely even look at a piece of cake, and then they get round everywhere. And that's actually a thing. There is a difference between how we deposit our adiposity. And so there's the visceral adiposity, which is in our stomach area, and that's the thinner person. And we call these TOFIs, right? Thin on the outside, fat on the inside. And then then there's the more peripherally obese, who tend to shuttle their insulin and glucose into their peripheral tissue. And so it really just depends on how your genetic predisposition of how you manage that. And you're absolutely right. There are thin people. Actually, some of the worst diabetics that we have are people who are quite thin, because maybe their practitioner hasn't noticed, like, oh man, it's usually the thinner people that we have to be worried about, because the thinner people are the ones that actually deposit their adiposity in their midsection, and that is extremely inflammatory, and that actually will impair also our vital organs' ability to process and to function appropriately. And so, because of that, their insulin levels are not able to keep up with the amount of carbohydrate load that they're having. And sometimes it's not even that much. And so these people have a little bit of a lower insulin level, but really high glucose levels. And those glucose levels will start to, cause problems in their entire body, usually, assisted by their vasculature. And then you get a lot of the end organ damage. So it's, these are the people that hear of the marathon runner who had a heart attack and was super thin. That person was likely diabetic and or had end organ damage and was probably carb loading. And then there are other people who are peripherally obese. Their pancreas works really well at shuttling, increasing insulin and shuttling all of their glucose into their peripheral cells. Their hemoglobin A1C is normal or below normal. And you look at them and you're like, how come you're not diabetic? But actually, the damage from the peripheral obesity is present because the peripheral obesity, the peripheral adipose tissue secretes cytokines and prostaglandins, which are inflammatory molecules that continue to wreak havoc on the rest of the vital organs as well. And so it just takes a little bit longer for that to happen. And so, yes. And then in gynecology, what we're noticing is that ladies who are thinner, the PCOS person tends to eventually get uterine fibroids in my observation. And those women, because they have such high levels of glucose in their vasculature, will have also similar inflammatory effect at the vasculature of their uterus, because the uterus is made of the same smooth muscle as our blood vessels in our body. And so if it receives that inflammation, it'll start to create these fibroid tumors. And so a little bit thinner women will start to get the fibroids, and then the ladies who are more peripherally obese will start to get the inflammation at the lining of the uterus, at the microvasculature. And so these are women who have normal appearing uteri, but the lining of the uterus is very inflamed and they have really heavy bleeding, or they eventually are predisposed to uterine cancer itself. And so absolutely, it really just depends on what your genetic makeup is and how your body, through the many polymorphisms, process sugar. And then that's how your manifestation of chronic disease will reveal itself.
That is quite insightful. I don't think we've ever looked at it from that angle when you look at a personal threshold, because you always tend to presume that when you say insulin resistant, they should be on the heavier side, they should be on the bulkier side, carrying a lot of fat. But then you suddenly see a very thin girl or a woman coming and saying that she's diagnosed with PCOS. It gives you a little bit of a shake, saying, oh, this is possible. I think your explanation really clarifies that. Thank you.
Oh, yeah, you're very welcome.
I'll move on to the next topic, I think, which is also your favorite and close to the heart, and abnormal uterine bleeding, because you've done a couple of papers on that. So currently, in this kind of an issue, the abnormal uterine bleeding or a dysfunctional uterine bleeding, the current course of treatment is largely oral contraceptive pills, right? But in your study, you strongly connect it to insulin resistance. And you're also mentioning low carb as a therapy. Can you help us with some insight and help us understand why? Because you have on one side, you have all the pharmas, all the doctors and hospitals pushing pills and, really recommending young women who have this problem to go on a hormonal pill. But you put it very simple in terms of saying that, no, it's just a change in the dietary pattern. So if we need more information, please.
Yes, thank you. And this is truly the essence of what I am trying to promote, because as OBGYNs, as gynecologists, we've done so much training and investigative discovery in pharmacology and surgical technique. We're really good at it. We're really great at treating women's acute medical problems and chronic medical problems. But I think that as doctors, sometimes we have overlooked the impact of diet and lifestyle in the development of these diseases. And so the American College of OBGYNs, which does give a lot of guidelines of how we direct our care, does promote lifestyle changes as the first line treatment for polycystic ovary syndrome. The problem is that many of us doctors don't know how to promote what diet really does make a difference. And so from purely a physiologic standpoint, that's why I think low carb lifestyle really makes sense to me, because physiologically it makes sense. If you reduce your carbohydrate load, then you're going to decrease your insulin, and then that will help women ovulate more and decrease the inflammatory response that initially begins with PCOS. And so from that concept alone, then we're able to really apply it to many different factors. And so what I think has happened in gynecology, though, is, and in a lot of primary care, is that we've siloed women's health as a problem of our female hormones and not as a problem of our insulin factor. And so, I have every day, multiple times a day, I have patients coming to see me who said that they need to see their gynecologist because of their female hormones, that there's something wrong with their female hormones. And yes and no, really the big modulator of all of this is insulin, because insulin is actually what changes the signaling from our brain to our ovaries and our uterus. And so if we don't focus on the root cause of disease and just treat the symptoms, then we're not doing anyone any favors. But it really depends on where patients are at, because I have patients who are just in the beginning stages of problematic gynecologic problems, heavy periods, irregular periods, but their blood markers are by and large okay. They're not anemic, and so there's a lot of room for lifestyle changes while they're trying to get healthy. Now, I have other women who are in the hospital needing blood transfusions or in severe pain or a large fibroid uterus at the size of a full-term pregnancy that they need more. And so, lifestyle is going to be a really important factor. But on the other hand, they do need medical and surgical management. And so my job is to really just share with women how they got there, because just because I can give someone birth control pills or surgery to help fix their immediate problem doesn't take away that this problem has been developing for years and years and years. And so it's a really great insight, because it brings a lot of patient satisfaction about how they got there. And then oftentimes when people have the choices of lifestyle, medication, and surgery, if they're in a stable position in their health, then they can choose, right? Because that's just what patients have the right to do. The patients have the right to choose what kind of treatment modality. But what really has made my practice incredibly fulfilling is that offering the lifestyle piece, or sharing how the evolution and the pathology of how women got to where they are, has been incredibly fulfilling for both myself and my patients, because they feel like it's not just because they're a woman that they are experiencing these problems. The way women manifest chronic disease is through, problems with their bleeding. But that's just because they happen to be a woman, not because they are a woman. Okay. And so that's really important. And men, they actually experience the problems very similarly, but in a different way, with erectile dysfunction and things. And they're starting to feel like, maybe I don't have enough testosterone. And that's only a small piece of the puzzle. It's years and years of chronic inflammation that has led to these problems. So. Oh, I don't think we can hear you.
Right. Sorry. Yeah, I think the pills do have a side effect, right? Long-term usage, because they are synthetic hormones and they are externally had, So irrespective of the safety or whatever the doctors may say, is it right to presume that consuming these contraceptive pills over a period of time can create a problem in the later stages?
That's a great question. And so, does long-term, contraceptive use, cause problems chronically? That really just depends on the patient. There are some people who are not candidates for taking, estrogen-containing contraceptive pills. And there are people who have a history of an embolus or a blood clot in their leg or their lungs. There are people who've had heart attacks or strokes, people who have blood clotting disorders, people who get migraine headaches with vision changes. And those are people who really do need to steer clear from hormonal contraceptives. But then there are, everybody else chronically, is it okay to take them? Yeah, it sure is. Will it cause some chronic medical problems? Well, it does slightly increase your risk for hypertension and heart attack and stroke, just for the reasons that estrogen does thicken your blood a little bit, and so, yes, if you already have those predispositions, then yes, it can cause some problems. So when you share with people about about those adverse reactions, then you can say, hey, does this work for you or not? Now, does it reduce fertility? No, it does not, but what I will share is that the way oral contraceptives work is that they actually block your brain's signaling to ovulate. Okay. And ovulation is kind of like what makes women feel like women. It really does rise. It makes your ovaries cause a rise in estrogen. And estrogen is like the fountain of youth for women. It makes us feel beautiful. It makes us have really pretty hair. It makes our skin really nice. It gives us a lot of and motivation, particularly during our ovulatory time. It makes people have a lot of libido and makes you interested in sex. And so when women are on birth control pills it blocks that, and it just keeps those levels stable. And so one of the big complaints that people have with being on birth control for a long time is that they have no interest in sex, or they feel a little bit depressed, or their mood just feels static. And so a lot of times people actually have like changes in their vaginal chemistries because of the lower estrogen levels from being on birth control for a long time. They will even have kind of complaints of like even menopausal symptoms of hot flashes, because the amount of estrogen that's in typical birth control pills is actually quite low. And so it actually decreases that to a pretty low state. And so a lot of people are very sensitive to that. And so birth control pills and, hormone therapies are very helpful for certain people who need a little bit of assistance. And a lot of times when patients are presenting to me with, pretty heavy bleeding, but they want to apply lifestyle changes to get themselves better. Remember, it took years for people to get to a point where they're at with heavy, painful periods. It's going to take a long time to also turn over the tissue repair and to heal those tissues. And so I always tell patients, this is not forever. We're going to be on this regimen just for a short amount of time, and then we'll kind of check to see how you do. We'll stop it. And so I think having that mindset of deprescription, of deprescribing something that maybe you might not need forever, really does make patients feel like, oh, okay, this isn't forever. This is just for a little bit of time while I'm starting to try to improve my lifestyle. And it really does help. And the reason why it helps is because it stabilizes the lining of the uterus. And so estrogen and progesterone, are really what cause a lot of the tissue growth with our uterus, but also in the lining of the uterus. And so if you stabilize those hormones, then there's not so much bleeding. And that's why patients feel a lot better in terms of their quantity of bleeding. It also addresses their painful periods, because then your body doesn't need to rely on so much inflammatory factors to push out the tissue that's overgrown in the lining of the uterus, because it's that your uterus is made to do two things. It's made to bleed and push babies out. And so your uterus is also a really strong muscle. And so as it's trying to push out the lining of the uterus, that can be exceedingly painful as well. And so birth control does kind of stabilize that. And, but it's fun. You just tell patients it's not forever, you're going to get better as long as you kind of follow the plan. And it takes some time, and I'm here for you. And it's going to be, one step at a time, because some folks are not looking for the quick fix, right? Some folks are really trying to help improve their lifestyle. And, as long as you have really good, healthy understanding of how long, sometimes it does take a little longer, but isn't that what we're looking for? We're not looking for a quick fix here. And so that's birth control in a nutshell.
All right. You're absolutely right. I think women today are more and more aware that they're not going to look for a quick fix, and they're not going to be pressurized by family or society to just go in for a pill blindly. And I think most of them, and I'm very surprised, and I'm actually very happy also to see younger women in their early 20s starting to take control of their life when they realize that there's some kind of a problem, and they just don't, crumble under parental pressure. So yeah, I think the combination of having a small pill along with a longer, lifestyle intervention does definitely work wonders. So in one of the earlier questions, and Dr. Andrew, you had mentioned that, these inflammatory factors do become stiff in uterus, and they show up as cysts in the later stages, right? Um, and we've been having a lot of older women, let's say around after childbirth, 35 plus 40, many of them who are increasingly showing uterine fibroids and cysts. They're becoming quite common actually. And in many such instances, when they go for a consult, the immediate solution that most of the gynecologists give them is, let's do a uterus removal. It's like your job is done, you've given birth to children, and what else do you have? So let's take it off. Now, now, what's your opinion on this? And I also have a question to ask, if you think, is this connected to lifestyle and food habits again? Does it have any connection with the dietary patterns that they may be having?
Absolutely. And this is one of my most favorite things to teach my resident doctors in training, is that the uterus is an end organ, and the uterus is made of the same smooth muscle cells as our arteries and veins. Okay. And so over time, with the impact of epigenetics, with basically our current gene polymorphisms, our predispositions because of our DNA, as well as our environmental factors that turn on a lot of these genes. And usually we see this in kind of thinner people, the viscerally obese people, that those inflammatory factors over time cause damage to the vessels and reparative mechanisms that over time will lead to what we call hardening of the arteries. And so that's called atherosclerotic disease. But in women with the uterus, your uterus receives that inflammation in a nearly identical way. And so when that happens, our smooth muscles of the uterus will start to experience tissue repair. And then that causes calcifications and the creation of these cystic lesions in the uterus called uterine fibroids. They're just balls of smooth muscle and inflammation. And so that happens over many, many years. But right now, we're actually seeing it a lot earlier. We're starting to see it in women in their late 20s and early 30s. And we used to just see this like in our 40s and sometimes even our 50s. But I'm starting to see it a lot earlier. I actually have a surgery scheduled for one of my patients who is like 24 and has like a 20-centimeter uterine fibroid. And she's not ready to lose her uterus. So we're going to go ahead and just remove that fibroid itself. But it's like, why, right? Well, the effects of chronic inflammation over time, has caused this tissue damage. And so, I think it's insulin resistance that leads to that. It's the experience of also, chronic stress and anxiety and even trauma that activates these inflammatory factors. And of course, carbohydrates that lead to the damage of the vasculature. So we do see this earlier. So I tell my residents, like, the uterine fibroids are just cardiovascular disease of the uterus. It's atherosclerosis of the uterus. And then once we look at it in that way, then wow, it just answers so many questions, because women who need hysterectomies are usually not the most healthy people, right? They do carry a lot of inflammation, a lot of chronic disease, hypertension. They usually have already had their gallbladder removed. They usually are either mostly viscerally obese, or peripherally if they have, heavy bleeding. And so, it really kind of just depends on how the diet or how the lifestyle is manifesting in their body. But, it is such a huge problem. It's starting to become earlier and earlier. I think when I was in training, 15 years ago, we didn't do as many hysterectomies, and now we're doing them more and more. And a lot of people ask, like, can lifestyle make these smaller? There is no study that reveals that, but I have many patients that anecdotally have said, oh yeah, I've done these kinds of lifestyle changes and my fibroid got smaller. And so I think that is just such an area for investigative discovery to really look into that. And, I don't think it could hurt. I think if really people are trying to be strict with their lifestyle, then it can only be a positive thing. And uterine fibroids, as burdensome as they are with, causing bulk symptoms and constipation and low blood pressure because of the pressure of the uterus on the vasculature, they're by and large very rarely would turn into anything cancerous. Okay. And so if someone decided to not do anything about it and really just delve into their lifestyle changes, I wonder if it could make a huge difference, and I'm still early in the field that I'm ready to do that study. I think we need to do that study. And, but there's nothing wrong with really pushing lifestyle as a treatment modality, because that's what we do for other chronic medical diseases that have the same manifestation of pathology. In fact, those papers that prove that the cells of the uterus are behave similarly as our arteries have been present since the 60s and 70s. I mean, we've known this for a long time, but unfortunately, I think with modern gynecology and the utility of pharmacology and surgical technique, we've moved away from understanding the root cause of these diseases. And truly, 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 it's metabolic problems that can lead to these things.
So I think then basically, like what you're saying, it should be the first lifestyle intervention rather than just go in for a chop and cut away, right?
It just depends. It really just depends on how impactful the fibroids are clinically, because I have one lady who can't even lay down flat because the fibroids are so big and she can't breathe because they're pressing on her vasculature. That woman, I don't know. I don't know how much low carb diet's going to be able to help her, and so, it's going to take a long time. And so, yeah, we're doing the surgery for her, but then now she knows and is armed with the information to prevent further problems. And so, I think if someone has smaller fibroids and they're not too impactful, why not? And if they're not bleeding, out, and I always kind of joke with my patients when we do hysterectomies, and they often feel like, thank you so much, you've saved my life. And I'm like, no, your uterus was trying to kill you, but it's because of the inflammation that happened. And so they're just so satisfied when we can offer surgical technique, but truly teaching them how they got there is the most important thing. So then they have their own choice of how do they proceed from there.
Absolutely. Brilliant. So my next question is on menopause, right? So there are a lot of challenges that women do face as they come closer to menopause, 40, 45 plus. So in your practice, what are the type of challenges you've seen, and what are some of the suggestions that you can provide where people of that age can, either manage these symptoms better or, get into an easy menopause or post-menopause?
Great question. So the way I like to frame it is that there are some very important transitions in female motherhood and womanhood, basically, that are associated with insulin resistance, insulin rises, hyperinsulinemia. So that's puberty, that's lactation, that's pregnancy, and menopause. Okay. And so what happens in menopause is that the decline in estrogen, and menopause, the perimenopause period lasts about 10 years. Okay. So it takes 10 years for all of these changes to happen. And so it's coming for me. I'm definitely, it's coming. And so, that being said, what happens is that the decline in estrogen will change our estrogen receptors in our adipose tissue. And so the adipose tissue will start to change, and the movement of adipose from our hips and our buttocks area will start to move into our abdomen. And so that adipose in our abdomen is very inflammatory and causes the insulin rise and insulin resistance. So women during the menopause period definitely need to be, I feel like a broken record, I'm sure you guys feel like that too, but like on a low carb diet, particularly during that time, because the insulin, there is significant insulin resistance that happens during that time because of estrogen and the remodeling of adipose tissue and estrogen receptors. And so, yes, it'll start to go into your belly. A lot of women who have or in the menopause transition have a lot of hot flashes, and they're just so uncomfortable at night. They can't sleep. But we do see that women who have less insulin resistance have less vasomotor symptoms. They have less of those hot flashes, the soaking wet at night. And so really, truly being on a low carb diet, particularly during that time, is very important. But a lot of women during that phase have trouble losing weight. And that's just because they haven't really changed their lifestyle to meet the metabolic changes that are happening. So, some people, a lot of my menopausal women say, I'm starting to gain all kinds of weight. It's all in my midsection and stuff. And I'm like, yeah, you really do have to stop the carbs right now. And you'll have a lot smoother transition. So yeah, so that's how it impacts in the menopause phase.
And how important is proteins at this phase?
Oh, yes, it's very important. It's because they will help with your satiety. And that's really the kind of the piece here, is that the fat and the protein is exceedingly important during this transition of life, because if you rely heavily on those, then you won't really rely so much on the carbohydrates and cause a lot of the, metabolic, negative metabolic effects that we're not interested in. So.
All right. I think just in connection with this, I have a question where someone wants to know is there any kind of a supplement or a food that would support these hot flushes? And does fasting also help during this phase?
Yes, fasting will definitely help because it'll really reduce those insulin levels, and that's a big one. And so, fasting, but also nourishing your body with a lot of the electrolytes it needs during those extended fasting periods. So, I don't really do anything more than like an 18-hour fast. And I think there are some people who like to do longer fasting episodes because they have other chronic medical diseases, and that's totally fine. But you really do need to supplement with, magnesium oxide or magnesium glycinate, some sort of magnesium to help with your metabolic processes, and as well as salt. Salt is really important during this time, to keep, your chemistries intact, and your ability to just kind of have those electronic connections in your cells so that they're working appropriately. Now, in terms of herbal supplements, there's a lot of herbal supplement formulations out there that are very helpful. I'm not too familiar with it because honestly, I get so much more bang for my buck by just telling people to reduce their carbohydrates, But yeah, I mean, for many, many years, there's been teas and herbs, and black cohosh comes to mind, vitamin E comes to mind. Those are really good, helpful supplements that I've heard that have helped a lot of patients. But honestly, the low carb diet really is how my patients receive a lot of relief during that time.
Now, when we talk about low carb diets, or when we talk about the ketogenic diets, you also read certain misinformation or statements that, say, let me not call it misinformation, but there are statements that say the low carbohydrate or ketogenic can cause irregular periods or cause amenorrhea or issues with periods in women. How true is this?
Yeah, I've not heard that. I think the only time that would cause amenorrhea or irregular periods, honestly would be that initial phase when people are on it and their body is transitioning from carbohydrate metabolism to ketone metabolism for maybe 1 or 2 months. But if your period stops while you're on a low carb diet, it might be that it's not a very well formulated low carb diet. It might not be enough fat and protein, and it might be more caloric restriction. And truly, again, your body's very smart. And if it senses that you're under a stress or you're in starvation, right, then it'll start to protect your ability to conceive, and it'll shut down your ovulation, which is what happens with people with anorexia nervosa and bulimia. And so when they have significant nutritional deficiencies, then your brain will say, no, it's not a good time to have a baby, and will shut down your ovulation. And so, yeah, I think, if understanding the chemistries and the metabolism will really shed light on what is happening, and having a deep dive into how a person is doing their low carbohydrate diet. It's not internet keto, right? It's not just looking at what the internet is saying and social media, but having really good prescriptive advice about how to do a well-formulated ketogenic diet or low carb diet makes the most sense. So
I'm glad I clarified that from you, because I was a little surprised when I saw this as well, because I've had people come to me and they say their periods have come on time without any medicine support, because they would earlier use medicines to induce their periods. And then once they shifted to a low carbohydrate, low sugar diet, the periods automatically sorted themselves. So I'm glad I clarified this question with you.
thank you.
So, Andrea, we just have 5 more minutes, and then I have one last question. I'd like to hear a unique case study from your experience where you've been able to apply the ketogenic therapy or the low carb therapy, and you've been able to see a huge change or a large improvement in their health.
Yes, one notable case that comes up, because I think that we get a little focused on PCOS and irregular periods. And we know that, when we apply a ketogenic diet, works really well and people do fine. But one case that really was exciting to me was this long-term patient of mine who had, she's probably in her mid-30s, and I've delivered, several of her children. She's had, 3 children, but the last 2 kids that she had preeclampsia, which is really high blood pressure, and protein in the urine, which can cause damage to our organs in pregnancy. But that occurred for her after she had her baby, which is not common, but it does happen. And so she was admitted to the hospital, and, she was super thin. She's kind of like, the thinner body type, the thinner PCOS kind of person. And she needed a lot of high blood pressure medications to really bring her blood pressure down. And then we got her through that, but it was kind of a conundrum. And when I asked her, what diet she ate, she was just like, oh, I just eat everything. And at that time I was so focused on her high blood pressure, I didn't dive into it too much. Well, about a year later, she came to see me, and she was having significantly heavy periods. I mean, like flooding through her bed sheets and unable to get out of bed. Her ultrasound was completely normal. She was just so debilitated, and she would have to have her mom come and help her with the children. And it was such a big deal. And so she came to see me, and her labs were okay. Her fasting glucose level was a little higher. It was like 99, and her insulin level was not really that high. But I thought, maybe she's a TOFI. Maybe she's like a thin on the outside, fat on the inside, where maybe that if we just still continue to reduce her glucose, like she'll help, not looking at insulin, but just looking at glucose. And I said, why don't you just try a low carb diet? And she's like, well, my husband's a vegetarian. We kind of eat that way. I eat everything, but he's very much vegan. And I'm like, everything we've been doing hasn't worked. Why don't you just get very hardcore about your diet for the next 2 months and just go low carb? And so she did, and she was all in. She's a pharmacist. And so she was like, I'm totally going all in. I'm going to just try this and see. And a month and a half later, she calls me and she was like, it's a miracle. She's like, my periods were so light. She's like, I was able to get out of bed and walk around and move, and I wasn't having any flooding episodes. I wasn't having to get up overnight and change my pad. It was just she was like, I cannot believe this. She's like, I just can't believe that we didn't have to use medications and stuff. And she continues to do better and better over the last year and stuff. And we're adding more electrolytes, and she's even noticing an improvement in her pain. So, even when patients don't have PCOS, but they have really heavy periods, there is a huge role at reducing glucose levels because of the damage that the microvessels receive from those problems. So,
wow, that is pretty interesting. Very good. Very nice. All right. So, Doctor, we've come to the end of our session, and I have Shashi with me.
Hi, Shashi.
Maybe if we could spotlight Shashi as well. So thank you so much for giving your insights, for sharing your time and your knowledge with us. I'm definitely sure all of this is going to be so useful to our population out there. It's been a
Thank you.
pleasure having you.
Oh yeah, it's such a pleasure. I'm just so grateful. So thank you for your time. And if you have more interested in more information, my YouTube channel is Conscious Gynecologist. It's please subscribe, please like it. I'm going to drop another video later today about IVF, and so I'm really stoked and happy to be part of this community. So thank you very much.
Dr. Andrea, thank you. Thank you for accepting this invitation and sharing this very valuable knowledge on women's health. And probably this is the only session we have, and we are so happy that you could be included, and you have been one of our international supporters also. You made a special YouTube video especially to focus on the session and announcing to the world that we are doing Metabolic Health Conference. I'm so thankful to you. And I know there's a busy day again. You are going to rush to your hospital after this. And we are so thankful. Thank you very much.
Oh, no, thank you. Thank you so much for your commitment. I mean, just the Indian community, but the world is just so blessed to have you and Anup and Anjali and all the background staff that have helped coordinate this. Thank you so much. I just, from the bottom of my heart, I really do appreciate all the time and effort. I mean, I know this is oftentimes so thankless, right? Every little piece that you're doing, but you're truly an example of a influencer in the world. So thank you very much.
Thank you again.